use more of these services than inexperienced industries. I believe the reasons they use more services are: first, preventing illness and disability is cheaper than treating it. Second, early intervention is cheaper than later intervention. And third, many disabling conditions such as drugs and alcohol, stress, and chronic diseases have their origins away from work. The result is that the occupational health field continues to expand to cope with non-work-related issues, for example, problems of lifestyle and chronic illness, the resulting disability associated with it, and the impact on the worker's productivity. Therefore, the distinction between occupational and non-occupational health care is blurring. Prevention of occupational disability requires programs which identify unhealthy situations and either prevent or intervene early in illnesses and injuries regardless of the cause. The employer and the workplace also have a lot to do with the prevention of disability. The employer who has an understanding of the multiple underlying causes of disability, regardless of causation, can provide a healthier workplace and improve productivity. We currently recommend to our clients the following practices: shifting the focus of corporate leadership in the direction of health promotion, prevention, and early intervention; making the work environment as conducive to good health as possible in terms of ergonomic design, opportunities for health education, and others; conducting pre-placement health evaluations guided by some assessment of functional ability; intervening early after injury or illness; implementing employee assistance programs targeted to document problems and provide intervention; and using a very aggressive program of disability prevention and management. All of these efforts by occupational medicine physicians and the employers and insurers we work with are done with the belief that these efforts will increase productivity. It is based on the following hypothesis. Human capital plays a major role for any employer. Healthy people are less costly to employ and more productive. In the end, good health is in fact very good business. This hypothesis is generally well accepted in the United States. Although generally well accepted, there has been significant discussion regarding the ability to prove this hypothesis. Some people believe that elaborate financial analyses are not worth the investment, and that all evidence tends to lend strong support to this logical hypothesis that healthy people are more productive. I personally believe that industry is still looking for additional proof. A few attempts in the literature include the following. There is a General Motors study in the early 1980s showing that for every $1 in health promotion, General Motors received $3 in benefits. A second example was entitled Benefit to Cost Analysis of Worksite Health Promotion in the Journal of Occupational Medicine. This was an analysis of the benefit to cost ratio of a health promotion program conducted from 1986 to 1990. The program costs for personnel, capital, expenses, material, etc. were determined and compared with program benefits for health cost savings, increased productivity, decreased absenteeism, decreased life insurance claims, and program-generated income. A benefits to cost ratio of 3.4 was estimated for the program. Another recent study, the effectiveness of vaccinations against influenza in healthy working adults, showed the following. This study concluded that the vaccination of healthy working adults has substantial health and disability cost savings. A benefit to cost ratio of 4.5 was found. Another study entitled The Effects of Health Promotion on Absenteeism and Employment Cost in a Large Industrial Population appeared in the American Journal of Public Health in 1990. This article evaluated the impact of a comprehensive health workplace promotion program on absenteeism among full-time employees in a large multi-location diversified industrial company. Savings due to lower disability costs at intervention sites offset the program costs in the first year and return $2 for every dollar invested thereafter. Another study done entitled The Financial Viability of Screening for Drug Abuse appeared in Clinical Chemistry in 1995. This study clearly demonstrated the financial benefits of pre-employment drug testing. For example, the United States Postal Service completed a longitudinal study on the economic benefits over the average tenure of the annual intake of employees. There were $100 million of savings. Further studies are being done currently, and industry is demanding more and more in return for their health care dollar. Whether it be group health expenses or occupational health expenses, industry is demanding more and attempting to shift the risk of some of the cost to the medical provider. I believe that further cost-benefit studies will allow industry and the provider to work more closely in the future. Currently, employers in all areas of the United States are looking at evaluating both health and disability for employees, both from work-related and non-work-related events. This is again blurring the distinction between occupational health and group health. It is also forcing medical providers to look at disability and functional ability as part of their standard practice. This is being driven by industry's desire to increase productivity by reducing the cost associated with both work-related and non-work-related health and disability problems. Terms being used for these efforts include 24-hour care, integrated health management, 24-hour care universal coverage, or a list of others. It basically means that industry is demanding from the insurer, provider, and regulatory mechanisms a way to look at the person, the employee, as a resource to be taken care of in total rather than in a series of segmented situations as has occurred over the past 30 years. The 24-hour care model has 4 parts: group health insurance, occupational insurance, group health medical care, and occupational medical care. By combining these pieces, I believe that we can provide cost containment of both health and disability costs for both work-related and non-work-related events. This is a result of savings produced both by the combination of insurance and the combination of provider services. For example, when the medical provider treats the patient for lower back injuries in the occupational arena, it lowers the health care costs on the group health side. And when the medical provider provides preventive services on the group health side, it lowers accident and injury rates on the occupational side. Additionally, insurance carriers are providing a lower total cost to industry if they purchase the combined insurance package. As a result, insurers are merging to provide both group health and occupational health insurance. Providers are developing occupational medicine programs and are beginning to extend disability management throughout their group health providers. And preventive medicine is being focused at all levels due to the cost containment objectives of the entire model. Those of us in occupational medicine believe that this combination model should have a significant effect in reducing the total health and disability costs and therefore improving the productivity of industry in the United States. It will require some legislative efforts, but mainly it will require that the medical community and industry find a way to implement the common theme that good medicine equals good business. A short aside regarding non-U.S. occupational medicine efforts. Governments and corporations around the world are becoming more conscious of occupational health care. For example, recently Mexico announced an alliance between the government and employers to propose modernization of its Social Security system. Central to this proposal is a plan to reduce workplace injuries. The government offers to lower workers' compensation premiums as an incentive to industry to invest in accident prevention and plant modernization. I applaud these efforts, and I hope that my presentation today will help you to learn from the U.S. successes and mistakes we have had to correct along the way. I look forward to your questions. Thank you very much.
Thank you, Dr. Fuller. Let us begin the second question and answer session. And to begin, we have a fax from Universidad Estatal a Distancia from Costa Rica, and that is the following question. The strategy you presented applies to technological and organizational innovation that takes place in our modern economies. Do you think these same strategies could apply to the traditional sector as well?
The short answer to that question, I believe, is yes, that the strategies do apply and will be of benefit. Perhaps there are a couple of comments that need to be made about the relevance of one or two topics that I mentioned, one being change, and is that even, for example, in Costa Rica, you likely will be facing change, in the upcoming years as perhaps technology impacts agriculture, as it perhaps increases the ability to produce things in the artisan trades. So by recognizing the change and how that will impact the workforce that you have, in managing the workforce that you have, that one is already trained, two has already been productive and is valuable to you, the strategies that we have spoken about, one, should be meaningful, and two, are extremely valuable to retain those good workers and keep them productive for you.
Thanks very much. We have now another fax from KTV in Rio de Janeiro, and this question is as follows. What should be the managerial style in the company or an organization to increase more productivity along the lines that we've been talking about this morning? What kind of managerial style should be employed in promoting this?
My belief there is that if you view the worker as an asset versus a problem, it points you in the right direction. As a physician, once again, I have been trained to view the human being as my major focus. I believe, once again, that the costs associated with industry and development will in fact go down if not only we as physicians, but the employer community and the insurance community takes that same tack, because once again that focus, in my belief, will lower the total costs associated with health and disability dollars.
Perhaps I could expand on the management style aspect of that question just a little bit. And for example, in the United States, we have gone through some relatively strong thinkings of management, from the classical style of management to the situational to the humanistic style of management. And I believe much of what Dr. Fuller is saying and what I would like to impart today is that the management style to be successful, as we sort of involve and invoke some of these strategies we've been talking about, should be one of involvement and inclusiveness of your workforce, making them feel that they are part of change and part of the response to change. And by doing so, I think our workforces will, one, be much more healthy as well as productive.
Thanks very much. We now have a live phone call from Instituto Tecnológico de Minatitlán in Veracruz, Mexico. Go ahead, please. Good morning.
The question is, financially, what percentage of the company's production should we dedicate for health areas, for the health area? Can we reach some acceptable health levels when the employer is the state and the provider of services is the state, and when the insurance company is also the state, the state, the country in this case, the nation, the government?
If I understand the question, it's how much of an organization's resources should be devoted to health prevention measures, occupational safety measures. I'm sure it must vary by industry, but what would be a good yardstick that might be used?
I will have to say at this point I'm not sure that I have a real hard number for you. I would offer, if the questioner wanted to leave their resources for me, that I would be glad to get some specific information for you from various examples in the United States, and I would be glad to get that information to you.
Okay, it is probably a very difficult question to answer just in one general answer, and it may have very much to do with the industry, with the economy and the regulations and so forth. So we will get back to you on that. We have now another phone call from Comisión Federal de Electricidad, CECAP. Go ahead, please.
Buenos días.
Good morning. As regards the human resources health, in what way what's the interaction between physical and mental, and how does this affect the employee, the workforce?
Let me see if I can rephrase the question a little bit, that there is a relationship between the physical and the mental health of a worker, and I couldn't agree more. I might say that what we have seen, and perhaps Dr. Fuller can expand on this, is that where the physical dynamics of a worker are impacted, so too are the mental aspects. They sort of go hand in hand, and by improving one, we almost always improve the other.
I think I would agree with you. They're inseparable. As I said before, the beginnings of the United States was that they started with the physical. They over the series of years have found out that the mental aspect is crucial. The combination is what to actually deal with, and it is oftentimes people don't want to deal with it because it's difficult to deal with, but avoiding it will simply cost you more money.
Next, we have a phone call from Panama, Universidad Tecnológica de Panama. Good morning.
¿Aló?
Yes.
Sí, sí. Si hablamos de la Universidad Tecnológica de Panamá.
We're calling from Panama, from the Azuero Center, and our question is the following. What do you think about a occupational health model where the company, the insurance company, is the same one that provides medical services? Do you think this is beneficial for the employee or the employer?
Dr. Fuller.
I will I may want to ask the questioner an amplification, but if the question is whether the insurance carrier can also be the medical provider or whether the employer can be all three, the answer is yes, it can be. Many large U.S. industries are, quote, self-insured, which means they do act as the insurance carrier. They also have the occupational physician within their institution. It becomes a cost-benefit analysis whether the size of the industry is enough to justify the expense of having an individual physician or a group of physicians within that. Large U.S. industries certainly have all of the above, and as they begin to get smaller, they generally hire independent physicians like those of us at Sharp Healthcare. We certainly take care of several thousand industries, from very small industries to very large industries, and so there's a wide range, and it simply is the size which determines that.
Thanks very much. Now we have a call from Universidad Autónoma de Aguascalientes. Good morning.
Buenos días, señorita. Represento un instituto.
I represent an institute, a social security institution from the state of Aguascalientes, Mexico. And my question is, the United States has reached a certain level of maturity as far as workforce and the average age, and they have had problems to resolve the payment of benefits, whether payments for disability, partial disability, permanent or total disability, or different kinds of disability. How can this have an impact? How do you think the programs that you mentioned through this conference, how do you think these programs can diminish the risk, reduce the risks, and And how does this, do you have any survey, any studies that you have some concrete results about?
The factor of disability associated with work-related injuries and non-work-related injuries are significant. Certainly in the state of California, about 3 years ago, many large construction firms were so strapped with the disability associated with work-related injuries that the entire profit margin for the industry was eaten up by the cost associated with those disability dollars. And so the total profit margin from some industries was being driven to zero or below zero by the cost. What this generated was an effort to reduce both the cost of the premium in a pure market-driven insurance product, but also preventive services have risen drastically in these workforces because those premiums and the disability costs, I should say, were driven so high. It varies widely from industry to industry, but certainly it is a big enough problem in the United States and in California specifically that prevention is a driving force now.
We have another call now from Argentina, and we hope that we can receive it this time from Universidad Nacional de Córdoba. Good morning.
Thank you. First of all, I want to thank the technicians for enabling us to communicate. We have a question. Could you please describe the role that the state plays in the company's policies, and what do you think of the pre-hiring examinations? Do we have to test for AIDS, and what should we do if they test AIDS positive? And what experience have you had in this regard in the United States?
Okay, we have then two aspects, the government regulation, if you will, and the pre-examination before hiring.
The role of the government is multifactorial in the United States. I'm sure it varies for each of your individual situations. In the United States, certainly the government has made workers' compensation insurance mandatory in all states. They vary somewhat from state to state, but certainly it is a mandatory thing. As part of my presentation mentioned, group health insurance is not mandatory, but very common throughout much of the industry in the United States. So the government will determine some by legislation, and the market forces will drive others. In any event, I think that you simply need to learn what the government demands and then do what the economics demand.
We have, I believe, time for one more question, and this would be from Comisión Federal de Electricidad in Monterrey. Good morning.
Good morning. What is the structure, the organizational structure, the minimum one that you recommend for us to have in the case of an occupational health department? What is the ratio between the size of the department and the number of employees?
Most U.S. workforces do not find it feasible to have a freestanding occupational unit within their site with fewer than 1,000 employees in that area, and I might ask Dan to calculate on that. And that'd been a brief answer.
I have seen those factors as well. Some organizations that have less than 1,000, for example, might have an occupational health nurse who is internal to the organization to help with workers' compensation and some training issues.
Thank you very much, Mr. Hopwood, Dr. Fuller. We hope that you have enjoyed this video conference. We will continue transmitting programs on the latest technologies available to improve your organization's productivity and effectiveness in the area of strategic resource management. We look forward to your participation on December 7th in the final video conference in our Telecommunications for Education and Professional Development series, entitled Video Conferencing and Interactive Telecommunications, technology, and training. For information on the International Training Center's programs for next year, you may consult your participant manual, where you will find the dates and specific topics of our programs. On behalf of all of us who collaborate with the International Training Center, I thank you for your participation and interest in today's program, and congratulate those who today complete the requirements for the certificate or diploma for this series of programs. We look forward to your participation in next year's programs and wish to thank you very, very much.